Well, welcome everyone to another episode of the Students Against Mandates podcast. I'm your host today, Sheldon Monroe, along with my fellow host, Camille Baciucci. Today we are very, very pleased to have on Dr. Harvey Risch. Dr. Risch is a professor emeritus of epidemiology in the Department of Epidemiology at Public Health School at Yale and Yale School of Medicine. Dr. Risch received his MD from the University of California, San Diego, and PhD in mathematical modeling of infectious epidemics from the University of Chicago. Dr. Risch was a faculty member in epidemiology and biostatistics at the University of Toronto before coming to Yale. Dr. Risch's research interests are in the area of cancer, etiology, prevention, and early diagnosis, and epidemiological methods. And I hope I pronounced that all right there. But thank you so much for joining us today. We really appreciate it.
It's my pleasure to be with you.
Wonderful. So, Doctor, we're going to break this interview into a few different parts there, but first off, we're just looking to hear historically, has implementing public lockdowns and quarantining healthy people been a standard response to a viral outbreak?
Um, no, actually, never. Quarantining of sick people has been a standard response. And to some degree, there's been quarantining of people who were very clearly exposed to sick people. But by and large, there has not been any quarantining of healthy people, presumably exposed people, or anything of the sort. And this was written out quite extensively by Tom Inglesby, who's head of the Johns Hopkins, now head of the Johns Hopkins Center for Infectious Diseases, or something like that, and Don Henderson, who was the public health figure credited with having eradicated smallpox from the world. They wrote a milestone foundational paper in 2006 describing all of the major methods that should be used for managing of respiratory virus pandemic. And they say explicitly not to quarantine or lock down healthy people, to let the population do as much as is normally possible to do in all respects, and only to protect basically high risk people, elderly people, and so on, and not protect them against their own wishes, but to offer them protection of things that they can do. And this is very similar to what was in the Great Barrington Declaration. But in fact, they had, Henderson had been formulating this early in the early 2000s, and they published it in 2006. And then when the COVID pandemic hit, it was militarized. The National Security Council was given control by President Trump a week after the emergency was declared, and they turned around and did almost the exact opposite of everything that was in the Henderson paper.
So why do you think public health implemented these lockdowns then? If it goes against traditional understanding of pandemic spreading of a viral, or spreading of a virus pandemic response, why would public health implement these lockdowns?
Mhm.
Well, that's not a straightforward question. The part of the question is answered by the reason that Henderson wrote this paper in 2006 was that there was already some sense in the influenza community of doing some of the things that we actually did in COVID. And he was aghast at this and put out his best knowledge, his experience in infectious diseases in that paper as a way of taking a stand against that. So there was already some stupidity in the general public health community about this. Secondly, you have to get at what was the goal of putting this into military control of the pandemic management rather than public health control of the pandemic management. And to some degree, our military and certainly our scientists are kind of in common knowledge and relationships with people in China. And that means, and even I have done studies, cancer etiology studies in China, but the public health people have been training Chinese virologists in our own labs. For example, Ralph Barrick, University of North Carolina, trained virologist, genetic virologist in his techniques, and they went back to Wuhan and started using his techniques on coronavirus. So we have, to greater or lesser degrees, lots of relationships with Chinese scientists. And so those people want to trust what they were being told coming out of China. Now, of course, this appears to have been, the Chinese appear to have taken advantage of what was a real pandemic, that I don't know whether the release of the virus was intentional or accidental. I suspect it was accidental, but there's no proof either way. And so they took advantage of it and made a theater show of draconian measures that they inflicted on their population. And we therefore had to copy them because we thought we didn't know anything, because again, the public health infrastructure had been going in this direction, thinking that what Henderson espoused was weak, when in fact it's not, because what prevents the best job of preventing the damage from a pandemic is called herd immunity. That means when people who are able to tolerate the infection and get over it without undue disruption of their life, without any kind of chronic or permanent side effects from the infection, you let everybody get that infection on their own terms. So at a time when they can manage it in their events of their lives, and so on, and where you have methods for treating it, and so on, to minimize the negative aspects of the infection, you let them get infected and develop herd immunity. Herd immunity is as good or better than any vaccine immunity. We've known that for thousands of years, how good herd immunity is. And now we've got a dozen studies or more, all showing the effectiveness of natural post-infection immunity for risk of getting COVID again, compared to vaccine immunity for getting COVID. It's as good or better, and doesn't come with the degree of side effects, biological baggage, as it were, of the vaccines. And so when the population develops its own major amount of immunity, then that is what subdues the virus and makes it very low level endemic, as it is now. And basically what we've seen in the United States, the CDC in the US does quarterly surveys of the blood supply to measure antibodies to COVID-19, to the virus, and to antibodies to the vaccine. And you can tell a difference because they're different antibodies, different tests. And so they've done this quarterly, except for I think there was a gap of 2 quarters in early last year. But the most recent survey was October to December of 2023. And in that survey, they estimate from their data that 87.2% of the US population has had COVID. Now, if 87% of the population has had COVID, then what good did all the measures that we carried out do? All those draconian measures of lockdowns, distancing, closing schools, closing businesses, all that stuff that created so much harm for the population in general, was accomplished almost nothing. Yes, maybe it spread out the infection to a little longer, the pandemic waves a little longer, but if, even the vaccines, if you look at, we spent 6 months of rolling out the vaccines in the first place, and then there was a big Delta wave hit.
Mhm.
Okay, well, so it didn't prevent the Delta wave. And then the mandates came in, in the fall of 2021, and another larger fraction of the population got vaccinated between Delta and January of 2022. And the Omicron big wave hit, and that was a gigantic wave that created a huge amount of infection, most of which was inconsequential. There were some people who were seriously affected, but compared to all previous COVID, it was minor. And so, what good did the vaccines do when these giant waves came about in the near term after major fractions of the population were vaccinated?
Mhm.
And then by the time of the end of last year, that almost everybody had gotten COVID anyway.
Mhm.
Now, purely for my own curiosity, would the notion or the notion of herd immunity apply the same way if um, if the viral infection is man-made as opposed to a natural consequence or a consequence of nature. Um, I'm not sure how that would play in or if there would be any difference.
There is no difference. The issue about why herd immunity is an effective and useful tool is that the mortality from the virus is small, very small. Even in the original strains of the virus at the beginning of the pandemic, the mortality from the infection was in the order of 0.2 to 0.3%, and almost all concentrated either in people who had some severe chronic conditions like obesity, cardiovascular disease, other major diseases, and who were very elderly, over age 80 or 85. Those were the target populations at high risk who needed protection. And at that time, we indeed had medications to use for treating this infection for outpatients when started in the first within the first 4 or 5 days, hydroxychloroquine and zinc, azithromycin, doxycycline, budesonide, which is an inhaled steroid. Um, Prednisone as an oral steroid can be given a little later in the course of the illness. And later on, we knew also about ivermectin. All of these things were very effective in preventing people from dying from COVID.
Mm.
And the fact is that they were suppressed for nefarious reasons, having nothing to do with the science, because the science is very clear. For example, for hydroxychloroquine, in the pre-COVID era, there are 9 or 10 studies involving now more than 70,000 patients, all showing that it reduced the mortality by 75% or more. And this is just as dramatic. No amount of supposed bias or confounding is going to give you numbers like that. And all the studies that have looked at this show this degree of mortality reduction. Nevertheless, it was only used for the first few months before there was official government and unofficial media suppression of this drug for what I would again call nefarious reasons.
Okay, wow. So when we talk about we're on the subject here of herd immunity, in Canada and as around the rest of the world, public health focused on case counts to attempt to justify the lockdowns. So it's a simple question here. In your opinion, was case counting an important measure for us to be following closely?
No, and Henderson says this in their 2006 paper also, that the only utility of counting cases is to generate fear in the population. That what matters is the consequences of the cases. So, in other words, the consequences of infection, getting long COVID, as it were, or being hospitalized or dying. Those are the things that matter in the opposite order. Dying is the first thing you have to deal with. And then once you solve that, then move backward to hospitalization and long COVID. But so those are the factors that need to be monitored. And it's the case counts it's exactly the opposite, because the numbers of people who get COVID by and large get immune from their infections.
Mhm.
And this is what Henderson was talking about, post-infection natural immunity that does as good or better than vaccine immunity and is safe for the great majority of people, because the mortality in COVID was concentrated in people who were definable. So we could predict who was going to be at significant increased risk. We could predict who would need to have measures that they should take to protect themselves and what measures they could use to treat themselves.
Mhm.
So I know you just touched on this, but if you had anything to expand on, I just wanted to know what was the exact risk of death from COVID across the age groups? I mean, who were the high risk age groups, and how much did comorbidities really factor into converting low risk age groups, such as, I mean, I'll let you explain who were the low risk age groups, but converting low risk age groups into a high risk demographic?
Well, children and young adults were essentially at zero risk of dying from COVID, unless in the rare instance they had severe chronic conditions like obesity. People don't recognize that obesity is a severe chronic condition. because there's so much overweight and obesity in our societies that we take it for granted, don't think twice about it. And by and large, people manage it, except when it comes to certain things that take advantage of obesity to do damage. And COVID was one of them. So obesity, children and young adults who are obese, they were at significant increased risk of dying from a COVID infection and should have been managed with hydroxychloroquine at the first signs of infection within the first 4 days, for example. And the other groups are the elderly people, generally because most elderly people have one or more serious chronic condition. It just comes with the territory of living that long. And um, so those are the people who needed the protection. The risk goes up with age, but in through age 60 or 65, in general, it's quite low of dying. And then it starts to accelerate up from there. But for sure, children and young adults have healthy ones have zero risk of dying from COVID. And that was true in the original part of the waves of COVID, the original strain of the virus, and now all the more so in Omicron, which is much less virulent compared to the original and Delta strains.
Now, this might be a leading question, but the university student age group would have largely been unaffected by COVID, if we follow that line of reasoning. Is that correct?
That's correct. There was no rational reason ever to have to mandate the COVID vaccines for students in general. Never.
So were universities to simplify that, were university COVID vaccine mandates, do you believe, a net benefit or a net harm to students in the overall sense there?
I believe they were a net harm because there never was a room for benefit. If you're going to reduce risks of dying, if you already have essentially a zero risk of dying to start with, then there's no room to make it better. There's no room for benefit. So they could only be a net harm. Now, the argument is that students could transmit the infection to professors, university staff, their grandparents, whatever. And that's why they had to be mandated to be vaccinated. However, that's a specious argument because in fact, it violates the approval of the vaccines in the first place. The COVID vaccines were emergency use authorized in the United States.
Mhm.
And that is not a regular approval. That is a different standard approval. In a regular approval, it's called a biological license approval, a BLA. In that approval, the manufacturer has to show that the product is safe and effective,
Mhm.
period. Proof that it's effective,
Mhm.
okay, and proof that it's safe.
Yeah.
In an emergency use authorization, it still has to show proof that it's safe, but it only has to show may be effective, not proven that it's effective. So
Yes.
that's the first thing. There never were any COVID vaccines to this date that have BLA approvals in the United States. The Comirnaty and Spikevax products are products in name only because they were never manufactured and released in the United States. Only the EUA versions were ever released in the United States, and they're legally distinct. Now, in the EUA approvals, the approval says specifically that the vaccine is intended to be used to reduce the risk of infection. That means the person who's taking the vaccine has, in theory, according to the approval, a reduced risk of getting infected.
Mhm.
That's how the vaccine was tested. That's what all the randomized trials looked at. And that's the question that's being addressed by the EUA approval. Furthermore, there's a general principle in US law that drugs and vaccines and medical devices cannot be marketed for purposes other than which they're approved. Now, of course, we have off-label usage of medical drugs and devices that follows long principles of our FDA, but that is something that is allowed by doctors themselves to choose, not by the companies to advertise. You can't advertise off-label for something that's unapproved. And I would say, therefore, you can't mandate something for an unapproved use, because it's violating what the original purpose of the approval was to establish defined conditions where the product has been tested against. And so the approvals in the EUAs for these vaccines were to prevent infection in the person taking the vaccine. However, as we know, the universities and other public employers have all said, almost entirely said, that we're mandating this to control the spread of the infection. Controlling spread is transmission. That means from a vaccinated person to somebody else. Okay. The vaccines, however, were never approved in the EUA for that purpose. And that means that mandating the vaccines for that purpose was technically illegal. That there was never an indication that the vaccine worked for that purpose, nor was it ever tested, nor was it ever approved for that purpose. And so there were no grounds to do this legally, and people smeared this distinction and got away with it for the longest time. Now you could ask, well, do the vaccines prevent transmission? And the answer to that is, for the longest time, we didn't really know. However, over time, a large number of studies have been done looking at what I would call enumerative or fixed environments for what is referred to as secondary attack risk, meaning transmission to a known identifiable person. It would be difficult to study transmission when you go and waltz through an airport lounge and there's 150 people there, and that's in fact why we don't do case tracking for an infectious disease like this, unlike a one-to-one infection like AIDS, where the numbers of people involved in the relationships of spread are more enumerable. Here, we can't enumerate large contact groups, so it's not appropriate to do it. In any event, so studies have been done mostly in households where one looks at an infected person bringing the infection into their household and looking at uninfected household members to see how many get infected over what time course. That's called secondary attack risk. And now there have been some dozens of studies looking at this process in households where the person who was infected had previously been vaccinated versus when the person who was infected wasn't previously vaccinated. Okay, the person coming into the house, the index case is infected either way. And the test is to look at the difference between whether that person had been vaccinated before or not. Okay? And the answer is that in the Omicron period, in the original period before Delta, that vaccination of that person who got COVID anyway made that person less likely to transmit the infection to household members, significantly so. However, once Delta hit in mid-2021, that disappeared. So there's essentially no difference in secondary attack risk whether the index case had been vaccinated before infection or not. And the same is true in the Omicron period. There's no difference in secondary attack risk. So technically speaking, the vaccines for the great majority of the pandemic have not prevented the transmission of the virus in those circumstances. Now, there are other studies, a few studies, there's a study in prisons where the people are definable, identifiable, and so on. There's a study in long bus rides in China where the people are all captive audiences, as it were, in the bus, and so on. And they also show no benefit of the index person having been vaccinated before contracting the infection again. So that's the story, that transmission is different than infection, that an infected person is just as likely to transmit whether or not they had been vaccinated, and so the vaccines are not doing anything to stem transmission. Now you could say, well, but wait a minute, the vaccines might make them less likely to get COVID in the first place, and if they don't have COVID, then they can't transmit. So the answer to that, of course, is that the vaccines only worked for a short time, that they
Mm.
worked from about 2 weeks after vaccination until in the first, doubled the paired dose at the beginning, um, about 4 to 6 months after the second dose. With each successive booster, it got shorter and shorter to the point after, 2 or 3 boosters, it's down into the 1 to 2 months period when the vaccines provided any reduced risk of getting COVID. And then there's numbers of studies that show that the risk benefit goes below zero, that people are more likely to get COVID after being vaccinated, after more time has occurred. The Cleveland Clinic study shows this in spades. The more doses of vaccine you got, the greater the risk of getting infected there were. And also, all of these studies are strongly biased by a problem of they counted people who got COVID within the first 7 to 14 days, depending on the study. Within the first 7 to 14 days after being vaccinated, they counted them as being unvaccinated. So they put those COVID events into the unvaccinated group. And that is improper. They did it by a bait and switch technique, which is that if you're looking for efficacy, and you want to look at so-called efficacy on paper, what's the best that the drug or vaccine can do? You wait until the drug is on board, till its maximum concentration, and then you ask, what's it doing now? And you ignore or throw out all of the time before. And after the drug has disappeared, you say, well, there's no more drug on board, so we're not going to look at efficacy then because it can't possibly have efficacy. It's too late already. So you try to create an artificial period when you think if there's going to be a benefit, that's when it should be. Well, but that concept was smeared into we're giving this and we're going to see what happens in the whole population forever. And in order to do that, basically, as soon as the person is randomized, before they even get the drug, they're in the vaccinated group. So if people thinking that they're participating in a trial and get into car accidents on their way to getting vaccinated, that counts as an adverse event, say. And so the adverse events that were occurring in the first 7 to 14 days were in fact getting COVID. And in fact, the vaccines had increased risk of getting COVID in the first 7 to 14 days before the initial benefit set in. And yet those cases were put into the unvaccinated group. If you put them into the vaccinated group, then the efficacy goes down dramatically. And that's the real world evidence, not the artificial contrived study that the FDA wink wink used to let the manufacturers demonstrate supposed better evidence of benefit than actually occurred. And of course, that went away over time for all of the vaccines to the point where on August 11th, I think, of 2022, August of 2022, the FDA put out a statement saying that 2 doses of the vaccine are ineffective in controlling the transmission of the virus, and that being so-called up to date with all boosters up to the present time provides a transient benefit that wanes. And that's their language. And to me, as a public health person, saying something, a method of controlling the pandemic that's transient and wanes, means the method is useless. In fact, what they're basically saying is you have to give these vaccines about every 3 months in order for them to do what they claim they're doing. And that's completely impractical and unsafe and would be beyond the acceptability of almost everybody in the population, except maybe some captive nursing home patients. So aside from that,
Yes. Wow. Okay. Well, so that, yeah, very pertinent to, I think, really, really connect with our listeners there, and particularly what's so pertinent to that response there is really a subject matter that's very important to our organization there and for our listeners as well, is the mandating of the shots in Canadian medical schools. We're still mandating the original COVID vaccine along with boosters today in 2024 for healthcare students, with the transient benefit. Waning after some time there, but with a continuous booster dose shot there, do you see any benefit in Canadian medical school students still being put through this mandated process there with the injection and then the booster shots at all?
no, there's no benefit whatsoever
Mhm.
that it's astonishing the stupidity of the public health and government institutions about this, that there was never a rationale for the mandate. At most, there was a rationale for offering vaccines to people who wanted to choose to take them under their own free will, without coercion, with full informed consent. That was the most. Even that, I think, was unwarranted. However, in a free society, there's at least reason to entertain that. There was never a reason to mandate this.
Okay. Well, so now just to get a little bit into the potential harm of the vaccines themselves, how common are COVID vaccine effects in side effects, pardon me, in university age students there in that cohort of age, 18 to really 25, I could say?
Well, fortunately, they're not that common. And I've analogized this to an engineer builds a bridge over a river, and the engineer says the bridge is 99.999% effective, and thinks I've done such an amazing job, 99.999% safe. And then he finds out that 100,000 people a day are driving across the bridge. And at 99.999% safe, that means every day somebody's going off the bridge into the river, day in, day out. And so the people in the community think that this is the deadly bridge. They've nicknamed this the deadly bridge because every day somebody goes off of it into the river. And yet it's 99.999% safe, right? And the people themselves who call this the deadly bridge think, oh, I have to go to the post office, and it's on the other side of the river. I'll just go drive across, because my chances of going to the river are virtually zero. 99.999% that won't happen. So I'm going to assume that won't happen. Yet at the end of the year, more than 300 people have died from this bridge, right? And so the answer to this is things that can be very uncommon. When you multiply them by the number of people exposed, a large number of people exposed to something that's very uncommon can become common, even though it's infrequent. It can be common for the population, even though it's infrequent on an individual basis. And so that's why there can be government and media propaganda that this is safe. The great majority of people who've taken the vaccine probably have not had any recognizable ill after effects. And yet there can be tens or hundreds of thousands of people who've had severe damage from the vaccines all at the same time, because those hundreds of thousands of people are small compared to 250 or 300 million people who've taken the vaccines. How do we see this in the history of vaccination in the US? The answer to that is that in all previous vaccines, when any number of these kinds of severe reactions have occurred, we pulled the vaccines from the market. And the reason for that is the vaccines are not being used to treat sick people. We tolerate medications that have much higher toxicity and harm for the promise of even better benefit in sick people. If you have cancer and you have a 30% chance of dying from your cancer, you're going to take a medication that has a 20% chance of killing you if it's got an 80% chance of saving you from dying from the cancer. It's a rational risk-benefit conclusion where you can calculate the numbers and show it's in your favor. But when you treat healthy people, there's no favorable benefit when they're already healthy. In other words, they're not at serious risk of damage if you don't treat them with the medication. And so any number of serious outcomes is going to overwhelm the actual damage from what you're trying to prevent. And so that's how all previous vaccines that did have some deaths or serious neurological damage and so on were pulled after half a dozen, 2 dozen cases occurred. And that just did not happen with the COVID vaccines at all. We were out to lunch on COVID because of a whipped up, anxiety frenzy by propaganda, but from the government.
I mean, yeah, I love the analogy there. if there is no risk of death or serious adverse effects from the contraction of COVID, then mandating a vaccine that even has a remote chance of affecting a perfectly healthy person seems nonsensical or borderline unethical.
Mhm.
Um, my question was, how does the rate of the vaccine adverse events compare to bad outcomes like COVID long or long COVID, or bad outcomes from COVID itself for students or for a healthy population?
Well, we don't have really good estimates of that because um, there's been a determined effect not to reveal the the true negative aspects and data of the vaccines. We do know something about the mortality from the vaccines, both in the short term and long term, and even that has been argued that it's not proof. The vaccines are associated with longer term increases in mortality in working age people. The numbers of insurance companies have seen that in their policyholders in starting in I think the end of 2021 into 2022. They started seeing those waves of increased mortality. We're seeing a little bit in cancer now, but cancer takes a few years to develop. The argument is, oh, it came from COVID, not from the vaccines. Seems implausible. There's so much of the population, as I said, that's had COVID, and it's not affecting the population in general. It's more specific to the insurance company data and working age people who are generally healthy. Um, the proof of this is difficult. There's evidence is strong, but it's not proof in the same way you might do 2 or 3 large randomized controlled studies to get much stronger evidence. So it appears from multiple places, multiple countries, that all-cause mortality is increasing after having been vaccinated. And countries that have had greater vaccination proportions tend to have greater increases in mortality. But again, this is correlative. It's not proof. It's just suggestive.
So just because you a really interesting add-on to that question Camille asked and your answer as well, Doctor. Have we seen any studies at all during this past number of years, 4 years or so there, that evaluate the harm benefit of the COVID vax, particularly for students? And if not, how would you design a study to answer this question?
Well, the harms are multiple levels. Mortality is the main one. It's not common from the vaccines either. Um, and then you have to start looking at serious illnesses like myocarditis, pericarditis, which now has been admitted is caused by the vaccines. And young adults, particularly young adult males, are about at the highest risk of getting this. Excuse me. And people are in outside of the medical community are in major denial about the seriousness of myocarditis. They think that because these people, go to the hospital for 3 days and seem to recover and get up and walk out of the hospital and resume normal life, that they've recovered from myocarditis, but they haven't, because myocarditis causes dead cells in the heart, and the heart can still work around those dead cells, but the problem is it's not working as well and as efficiently as it did before the myocarditis. And what that leads to over time is, if those dead cells are in an area through which the cardiac electrical impulses go from where the impulses start in the pacemaker section of the heart that creates the impulses to the muscles of the heart to make them contract. If those dead cells are anywhere near any pathways like that or adjacent to those pathways, they can divert the impulses, cause doubling of the impulses or blocking of the impulses, causing what are called arrhythmias in the cardiac rhythm. And these can be dangerous if they happen over time or happen suddenly. And so there's an increased risk of that. And there's also an increased risk of heart failure now going out 5, 10, 15 years, that mostly in people who have these mild cases are feel like they're normal and can do normal activities, but it doesn't stay that way over time. And that's the problem with myocarditis, that becomes a chronic condition over longer time periods. And so people who've had the disease now are likely to have their life shortened because of this. And, the medical in administration and so on, the United Public Health Administration in the United States is just in complete denial that this is a serious outcome, that even though people who've had myocarditis look like they're functioning normally again, they're not. And they have long-term potential serious consequences.
And you bring up a really interesting point. I just want to touch back on there because I think it would be remiss if we didn't ask the question there. So, is there an association between the COVID vaccine and an increased risk of cancer of any form there?
The answer is probably yes, but we don't really have good data. We have suggestive data that there's been an apparent increase in rapidly progressing cancers, referred in lay terms as turbo cancers, that um, progress so fast that between when a doctor evaluates the stage of the cancer and when the patient comes back a few weeks later for treatment, it's progressed, measurably progressed in that time frame. We're seeing some cases of young people, with cancers that only occur in the middle age and old, that take a long time to grow, and they're occurring in younger people. We're seeing reactivation of cancers in remission, like breast cancer, in middle-aged women, where it usually happens in older ages. And so these are suggestive things. There's also been a suggestion of increased risk of leukemias and lymphomas, which are blood cancers, which are the shortest latency cancers that take 2 to 3 years on average to come to diagnosis. Now we're about in that time frame where we would start to expect to see if the vaccines cause something. People who got vaccinated in 2021, now are at risk for developing a diagnosis of leukemia, lymphoma in the 2023-2024 period. So we're looking for that.
Just to pivot a little bit, we were wondering, have you been able to discuss any of what we've talked about today with your colleagues at Yale? And is anyone at Yale talking about these potentially serious consequences or effects from not only the mandates, lockdowns, but the vaccine itself?
So the answer to that is yes, but sparingly, privately. I've had colleagues who talk to me privately and say they agree with me and they think the same thing, but they just don't feel that they want to take the risks of speaking out. I have one colleague who was very skeptical, Dr. Iwasaki, who was very skeptical at the beginning of the pandemic of all of this. And about a year ago or a year and a half ago, she had an epiphany that the vaccines were indeed causing damage to some people, and decided to do a web-based recruitment study of people who had severe after effects from the vaccines, and has been working on that study.
So, kind of a more of a generalized question here, but as we wrap things up here, just wondering, following the COVID mandates at universities, how do students and professors go forward?
Well, difficult question. Students have very little say in things unless they band together. And, we've been seeing a lot of disruption lately in universities of students banding together for what I consider bad reasons, and not doing it for freedom of thought, but for freedom of bigotry. In any event, what it shows is that students who do organize can get a better result from their administrations. And sometimes this comes down to lawfare, in addition, that universities have not, in my opinion, universities have not mandated the vaccines for scientific reasons. What they've done is their attorneys have said, you have to be seen to be doing everything you can. So if something bad happens, your legal exposure is minimized because you can point to and, we did what the CDC said. We did everything we could, and it happened anyway. So they have an excuse. And then they cherry pick the science to support what they think is their excuse, and that's how they've managed their legal risk. They haven't done this objectively. They could have managed it by saying, we support students who want to get the vaccine, we'll make it available and free and so on, and you choose, but you're not required to. They could have done that, and that would have been a much more sound, properly motivated response to the pandemic. There has never been a scientific rationale or a legal rationale for mandating the vaccines. We can argue about whether there was any period of risk benefit parity throughout the pandemic for the vaccination. I argue that there haven't, but you can argue that point. But what's not arguable is that you needed a mandate to enforce it. After all, if something was so good as you're claiming it's so good, people will take it. Okay. If people aren't taking it, it's because they know that you have to mandate it in order to ram it down everybody's throat because it's not so good and people know it's not so good.
Yeah.
We'll wrap this up with our classic STEM question. Do you have any advice for students or future doctors regarding a potential approach to dealing with something of the likes of what we've seen? I mean, I know it must have been extremely taxing on you both socially and professionally, speak out and stand up for what was right. What guidance would you provide to students in order to stand up and risk, everything you've worked for? Do you have any guidance that you could provide to students?
Well, it's the same guidance that I give to everybody, which is stand up the best you can and have a plan B. Okay. If negative consequences happen to you, you need in your back pocket what I call a plan B, a workaround for doing what you want to do in life in the near future, whatever it is. Okay. Until this problem changes. And that could mean taking a pause in your education, transferring to a different school, something like that, getting an exemption, a medical or a religious exemption where those are available. You need to use all the tools at your disposal. And it could also mean lobbying, getting large numbers of students to push back against the administration, large numbers of students refusing, and things like that. If 1,000 students refused a mandate at a university, it's such a newsworthy event that the university would be embarrassed over it. Universities do not like to be embarrassed because it disrupts their donor campaigns. So, you need all the different tools that you have available to be able to be secure that the path you choose in life is the one you're going to be content with later in life when you look back and say, who was I at that time period, and what did I do, and how did I carry myself, and what did I espouse, and the satisfaction of doing things right that you look at later in life, it can be very important for what your life goals are. Not just am I making a living, am I doing the job I want to do, but how did I get here to do that? Did I do it right? Did I stand up for things that are right? People don't recognize how important this can be to one's self-concept over time. And so if you can do that, not everybody can do it, not everybody can get a plan B, but if you can have a plan B, you have some kind of resource that you can make use of, some way around it, then that's how I think everybody should approach this.
Well, wonderfully eloquently said, Doctor. And that is a fantastic place to wrap it up. We thank you for that, all your thorough answers there, and your advice as well. And so, thank you so much for taking the time to help inform us. It's been very appreciative.
My pleasure. Great to be with you.
Thank you, Doctor.